At Solis Mammography, one thing that we do, and one of the reasons why I joined the company, we put the patient first. When screening mammography was first implemented in the 80s, it was on an annual basis. And for the first 20, 25 years, the benefits of mammography were very apparent. Now, in the late 1990s and 2000s, all of a sudden, the United States Preventative Task Force came out with new guidelines. None of the studies were actually based in the United States. So for them to come out with guidelines beginning at 50 and going every other year, I think started creating a lot of the confusion that's out in the public today. One of the things that I always find myself kind of even internally trying to answer is, what's the message that they're sending to our younger women, right? Because typically women that are diagnosed with breast cancer in their 40s tend to have a much more aggressive cancer diagnosis. So we want to make sure that we identify those women as early on in their treatment outcome as possible. I think early detection begins with starting screening at age 40. If we can detect breast cancer at stage 0 or 1, the likelihood of cure at 5 years is approaching 100%. We've had screening mammography now for over 30 years. And when you look at the data, when you look at the mortality rates from breast cancer, there's no question there has been a greater than 40% decrease in breast cancer-related deaths after the onset of a screening program. Mammograms are effective, and mammograms save lives. The difference between Solis and any other breast center is that we run every breast center to the highest and most clinically relevant accreditation standards, whether it's a screening-only facility or whether it's a facility that's inside of a hospital. You get the same technology, you get the same patient-centric focus, and you get the same clinical expertise. A lot of breast centers do not have breast-dedicated radiologists. They have general radiologists who also do breast. When you look at the scientific data, dedicated breast imagers have a lower recall rate. They have a higher cancer detection rate. They have a better positive predictive value. If you have the same exam being offered at the same price point to the patient, why not send them to a better center? A better center from a technology perspective, a better center from an experience perspective, and a better center from a clinical perspective. Something that we encourage all of our radiologists to do is to actually have a one-on-one engagement with all our diagnostic patients. And we make sure that you understand everything that we saw, everything that we're going to be putting into our report. So when you walk out with the sheet automatically and immediately knowing what the outcome of your workup was. In order to promote compliance, the patient has to feel comfortable from the minute they walk into our center to the minute they walk out from our center and to the end point, which is when they get their results. Being able to provide all three and in a continuum of care is very important. And we have a very active dialogue with our referring physicians. So all of our physicians call the patients, give them their pathology results, but also turn around and call the referring physician. I think there's a lot of overlap as to what physicians and patients need to know. As radiologists, every time we read a mammogram, we have to classify the density of the breast. The research has shown that higher density patients have the same lifetime risk of breast cancer as if you had a first-degree relative. So putting it into perspective, it's a substantial risk. And there's no way of you knowing what your breast density is unless you have a mammogram. Technology is better, that the reports that they're getting are much more accurate, and in the right environment, the clinical expertise behind those reports really should give them a lot of comfort that their patients are getting the best care when they entrust their services to centers like Solis. So I think the future of mammography, just understanding what is my lifetime expectancy or possibility of developing breast cancer. So let's say that you are diagnosed as high risk, you would be kind of asked to do is to undergo annual screening MRI. MRI is extremely expensive, not widely accessible. So one thing that we're actively working on is how do we address that high-risk population with a more accessible, lower-cost alternative. So we're putting a lot of our research and development money and time behind contrast-enhanced mammography. And basically what it does is it creates the same imaging environment as an MRI, but at a much lower price point and with wide accessibility. 7 out of 8 women will never develop breast cancer, which is great. 90% of the women who come into our centers get a great letter that says, we'll see you next year. I think understanding early detection is key.